Well, it's 12:30. I'm a big proponent of starting on time. Thank you for spending your lunch hour with us. This is, I think, will be very interesting data for a lot of us, and thank you for being here. My name's Tom Heywood. I work at the Scripps Clinic in San Diego, and I'm going to kind of start us off here telling you a lot of things you already know, but that's okay. Somebody has to do that. I'm the moderator, so I'm taking the hit on this one, but these are all the issues that we have to deal with on a day-to-day basis in heart failure. But at least I get to do it in a nice place. So these are my disclosures. And apparently we get extra time. I don't think I'll need it, but so we're going to be talking, you know, I always like to start with a literary quote, and Charles Dickens is a great place to start. In The Tale of Two Cities, in heart failure, we really live in the best of times and the worst of times. I think people that go into heart failure are usually incurable optimists, because people that aren't heart failure people, how could you possibly do that? It must be terribly depressing. But we know the secret is that many of our patients can get better. We certainly do lose patients, but we work strenuously that patients can improve, and we're happy every 10 years or so when we get a new medication that we can extend patients' lives and do a much better job than we used to do. We don't have to cut up beta blockers in clinic like I had to do many years ago. But what more can we do for patients, and what are the challenges that we still struggle with? Oops, that's not working. Let's see, let's see, how about this? Does this change slides? That doesn't change the slides. I should have.
Page down, does that work?
No, that doesn't work. Page up, that doesn't work.
If you hit escape.
Not this one. I'm using my time.
Maybe the cursor is off.
Oh, that's not good. Yep.
Hold on, technical difficulties.
There we go. So what did you do?
Oh, I think you just, the cursor was off.
Oh, I see. Okay. Well, now I've fixed it all for you guys, so you don't have to do this. So
Good.
these are the 4 pillars, and we've gained lives as if we do this well, and this is what we all try to do in our programs, is to make sure that patients are in the best possible therapy that we can so that we can extend their lives. It was funny, when I was sitting in the last meeting, one of my friends from my previous institution that I left 19 years ago sent me a picture of a patient who she's still taking care of with heart failure. So people can live a long time, obviously. But in the midst of our enthusiasm, we have to be realist and recognize that many of our patients still succumb to heart failure or other things, and that despite our good therapy, mortality remains high in this disease. About a 50% 5-year mortality has been quoted. There are competing mortality causes, but our patients do succumb to heart failure eventually. It's one of my favorite slides from the Onion publication, a satirical magazine. They reported from the World Health Organization that mortality is holding steady at 100%. And I do tell my patients that despite my best efforts, mortality is holding steady at 100%, but I'm going to do my damnedest that they don't die of my disease, that they die of somebody else's disease, if I can possibly help it. There are significant challenges to what we do, and that's why we create programs to assist in these challenges so that we can have better outcomes and make sure patients stay on therapy. Blood pressure remains a constant struggle. When I started heart failure, it seemed everybody was hypertensive. Now it seems that everyone I see in clinic is hypotensive, that I've totally destroyed any blood pressure they might have had, and I'm trying to fiddle with medications to try to have a little bit more blood pressure to deal with. Comorbidities remain a large problem, especially renal function, and these can severely limit what we can do with some patients. I don't think a clinic goes by when I don't talk about money with patients and commiserate with them about the therapies. And oftentimes the number one reason I can't do what I want to do is because of cost. And I can totally understand that. We cut pills. I write larger prescriptions for medicine so that they can take half of it and afford their meds. My case managers help with patient assistant programs. Side effects are a real problem, both real and perceived. Pill burden, the number of pills we're giving people, and just provider resources. I can't see patients back as quickly as I would like to because of time. I just don't have the time in my program to see patients back as quickly as I would like. I just hired another nurse practitioner this week because of that issue. Our patients like numbers. The classic question, how long do I have, doc? They especially like their ejection fraction. They kind of perseverate on ejection fractions. If it gets lower, I don't tell them. If it goes up a little bit, we all celebrate, and we're very happy about that. BNP number, various studies have shown different things with BNP, but one thing I like about it is if the BNP remains elevated, I can use it as a data point and say, why am I adding another med? I'm adding another med because this number indicates that you're still at considerable risk, and I want to reduce that risk. I like you. I would like you to keep coming to the clinic. So it's not just that I'm doing things by rote, but I'm trying to reduce your risk and keep you around. We do have excellent data that patients who have N-terminal BNPs over 1,000 have a much worse prognosis, and that those that we can improve BNPs, their prognosis improves. This is a study that was kind of disturbing, that the out-of-pocket expenditures for patients with heart failure is about $5,000 a year. And I see that, I think that bears out in the patients that I see in our program, that they're spending many hundreds of dollars a month often for their medications. And on a limited budget, this can be tremendously difficult for patients. Hopefully this is going to change in 2025. We finally are able to negotiate with pharmaceutical companies, and sacubitril, valsartan, and the SGLT2s are on the top 10 list of the drugs that the government wants to negotiate a lower price. So hopefully that will help. There's also going to be a cap of $2,000 on out-of-pocket expenses, and I think that will be a major benefit for our patients. So maybe help is coming on that standpoint. Oh my gosh, what happened? Sorry about that. Your moderator is having tremendous difficulties with this. I don't know why that changed. It seemed like okay. We can spend a lot of time trying to get our patients on the medications, but whether they stay on the medications, there's a fatigue. They don't get their prescriptions refilled. Cost continues to be a problem, but even when we've gotten to the point where we get them on all the therapies that we want, these can decline. Okay, now, why is this happening? Okay.
There you go.
This could be a problem.
We can do CRT therapy. I was at the debate for devices, but many of our patients don't qualify for CRT. I think we're being a little bit more discriminating when we put CRTs in patients, knowing that some patients benefit more than others, the ischemics less so. So there's certainly a tremendous device, but there can be problems with CRT with non-responders, et cetera. The other problem with GDMT that I've been focusing on more is that although we can make patients live longer, we often don't make them feel better with GDMT. That quality of life improvements and exercise improvements are often quite modest in the trials. We don't see the same effect as when we do a heart transplant or we put in an LVAD where we get 6-minute walk times that go up by hundreds of meters in those patients, whereas we don't see that with guideline-directed therapy as much. And patients are very focused on quality of life. That's where they live. They feel bad. Heart failure is very debilitating at times. And in studies that have been done over the years, patients would trade some of their life for more quality of life. They want better life rather than more life. And some patients would trade a significant amount of time that they have remaining for better quality of life. And I think we haven't focused that enough on our studies, quality of life. They have mobility problems, they have pain and discomfort, and they have anxiety and depression that we often don't address as much as we should. We want patients to live longer, but they want to feel better. I've often termed this, and I think one of our problems with medical therapy and heart failure is this conundrum of preventive medicine. Nobody ever comes into my clinic on Monday and says, thank you, Dr. Heywood, for the medicines you prescribed over the past few years. I was scheduled to die last night, but your treatment has extended my life. However, every side effect, every imagined side effect and cost are blamed on the medications. For the next 6 months after you start a medication, whatever happens to them is the fault of that medication. And I think it's one of the problems that we have continued noncompliance with medicine. So we have this continuum of heart failure. If you take all the patients with HFrEF, most of our patients are eligible for guideline-directed therapy. Not all of them. We have patients with renal dysfunction, continued low blood pressure, et cetera. But we work very hard and very diligently to get patients on the appropriate therapy. But one of the problems is that patients don't often feel better. Sometimes they do, of course. We decongest them. They do feel better, but not all of them feel as better as they like. They don't feel well enough often that they ascribe how good they feel to their medications, and they just see the problems of taking their pills in terms of the cost and the inconvenience, and they don't have the trade-off of feeling much better. If you compare this with transplant and LVAD, it's revolutionary. Patients are dying, and we do a transplant or we put in an LVAD. They have not only many more years, but their quality of life is substantially improved with these therapies. Unfortunately, it's vanishingly few patients that we can offer these therapies for a number of reasons, so that this is really a minority of patients that we can have this tremendous improvement in quality of life for them. And so for most of the time, for the vast majority of our patients, it's guideline-directed therapy. CRT offers the benefit of the addition of improvement in 6-minute walk time and quality of life, but again, only a minority of patients, much more than transplant or LVAD, but still the majority of heart failure patients are not appropriate for that. So we still have this vast middle ground of unmet need where patients are on good therapy, they're not sick enough for transplant or LVAD, they don't qualify for CRT, or maybe they do, but they still have significant symptoms. They still remain class 2 and class 3. What are the things that we can offer them to try to bridge this gap, moving to continue this extension of their life, but also give them a better quality of life at the same time? And I think that's what the rest of this meeting is about. So thank you very much for attending today and putting up with my terrible slide skills, but I'm not sure it's all my fault.